Thank you, Dr. Gleave. And good morning, everyone. I'm excited today to present a grand rounds on social determinants of health in urologic disease. As Dr. Gleave said, I'm a PGY5. So let's get started this morning. I'd like to thank Dr. De Los Reyes and Dr. Kim for their help with this presentation. And I want to start this presentation with a land acknowledgement. I'd like to acknowledge that I'm presenting today from the traditional, ancestral, and unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I would also like to acknowledge that you're joining us today from many places, near and far, and acknowledge the traditional owners and caretakers of those lands. As we discuss health inequities from all sorts and origins today, I think it's important to reflect on how the history of these and other injustices still impact modern healthcare. So today we're going to be talking about social determinants of health. I think a topic that a lot of us know intuitively affects urologic medicine, but perhaps not the exact scope in the scientific literature behind. So today I would like to describe and define relevant social determinants of health, as well as indices of measurement. And then we'll be transitioning after definitions to a broad scoping overview of how these factors affect patients in domains of pediatric urology, trauma, lower urinary tract symptoms, and oncology. And finally, we'll end with a discussion of solutions to address social determinants of health, both from a research point of view as well as a clinical standpoint. So let's get started with some definitions. What are social determinants of health? Well, according to the Government of Canada, determinants of health in general are the broad range of personal, social, and economic and environmental factors that determine individual and population health. And social determinants of health refer to a specific group of social and economic factors within the broader determinants of health. So of these 12, basically it includes everything except for biology and genetic endowment. And we'll be touching on quite a few of these other lists in the 12 as well throughout the course of this presentation. Starting first with gender. So I'd like to point out that gender is now recognized to be a spectrum as seen on the right-hand side, boy to girl with everything in between and not just a binary. But there is lots of evidence out there for gender diverse people, so transgender people, non-binary people having poorer access to health and health outcomes. This will not be a sort of strong focus of the presentation. So just a heads up that occasionally I may refer to gender binary during this presentation, but I want to acknowledge that there is quite a bit of literature about gender diverse people out there as well. When we talk about race, we often talk about visible minorities, and StatsCan defines those as persons other than Aboriginal peoples who are non-Caucasian in race or non-white in color. Aboriginal people, Indigenous people are often classified separately when it comes to race. However, when we talk about race, I think it's really important to think hard about where our categorization of race comes from. In a lot of traditional race-based studies, they use this definition on the left, so the traditional categories from the U.S. Office of Management and Budget, which is broken down into 5 races and 2 ethnicities. So you have white, Black or African American, American Indian or Alaska Native, Asian, and Native Hawaiian and Pacific Islander. Surprisingly, Middle Eastern or North African is a new category that was added just last year. In terms of ethnicity, you have Hispanic or Latinx or non-Hispanic. The current Canadian census has a few more categorizations for race. So compared to the left-hand side, we have Asian broken down further into South Asian, Chinese, Filipino, Southeast Asian, West Asian, Korean, and Japanese. We have the addition of Arab, and then we also have other. And like I said previously, Indigenous peoples are categorized separately into First Nations, Métis, and Inuit. What you'll notice, though, is even amidst these categories, there are really large chunks and really big gaps where lots of people are sort of grouped together into categories that may not be the best fit for them. And again, many research studies are using the left-hand side to look at race, which didn't even include Middle Eastern and North African until last year. So really, I want to start introducing this idea, the concept of looking at race and studying populations based on race may be imperfect. And so it brings up the question, should we even use race at all? And I want to discuss this landmark paper that was published in the New England Journal of Medicine in 2020 called Hidden in Plain Sight, reconsidering the use of race correction in clinical algorithms. And this paper really challenged the idea of using race in medical studies, using race in clinical algorithms. They basically said that race might not be useful in clinical algorithms, and that studies of the genetic structure of human populations continue to find more variation within racial groups than between them. Moreover, the racial differences found in large data sets most likely often reflect effects of racism. That is, the experience of being Black in America rather than being Black itself, such as toxic stress and its physiologic consequences. So in essence, they posit that race is a sociologic factor and not necessarily a biologic one. And, they bring up, and I think it's important to think about, the thorny question of using race as a biologic factor in characterizing people for clinical algorithms. For example, how do you account for mixed race people, which are becoming a increasing percent of the population? What category do they belong in? Do you apply certain risk factors to them? What about people of similar race who grew up in different settings? We know, for example, in the prostate cancer literature, that those of East Asian descent who were born and grew up in a North American setting have risk factors more similar to others in the North American setting than those of East Asian descent who grew up in East Asia. And also, as noted before, the racial categories can often be imprecise. So, for example, Black can refer to several different nationalities, and indeed, studies have shown that populations described as African have the highest levels of genetic variations within them. This paper points out several urology-specific examples of clinical algorithms that have race in them. One is the Stone score, which is published in the BMJ in 2014 by a group out of Yale. It was a clinical score, the goal of which was to predict the presence of ureteric stone based on symptoms, so basically a pre-test probability before you would get a CT. Of them, their risk factors included male, non-Black, short duration of pain, nausea, vomiting, and microscopic hematuria. So you'll note that if you had a Black patient before you, you'd give them a lower score, which could lead to under-investigation and under-treatment. And indeed, there was an external validation study done later that disproved the race factor of the Stone score. There's also the UTI calc, which is published in JAMA Pediatrics in 2018 by a group out of Philadelphia, which again is a clinical score calculating the probability of UTI in a febrile child under the age of 2. Their risk factors include age, non-Black, sex and circumcision status, maximum temperature, and alternate source for fever. And similarly, they give a lower score by default to patients who are Black, which could again lead to under-treatment. And so I think it's important to note that this paper, doesn't change everything. I think it still begs the question about whether or not race should be used, but it has led to some practice changes. So in BC, Life Labs adopted a new EGFR calculation, the CKD EPI 2021, which does not take race into account. And in their press statement, this was made effective just last year, April of 2024. They said that this new GFR calculation has been assessed externally to not have potential consequences that disproportionately affect any one group of individuals. Whereas the previous GFR calculation often overestimated the GFR of Black people, which could delay practitioners offering them treatments for end-stage renal disease like dialysis or transplant. Nonetheless, I think this discussion of race is a fraught one and not without nuance, and I don't think we should throw out the baby with the bathwater. And throughout this presentation, I'll be citing many studies which are investigating race, but I wanted to bring this up first in the definition section so that we approach these studies with the correct context and take these results with a grain of salt. I'd like to move on to discussing socioeconomic status, which is another important social determinant of health. So this is status relating to income, education, occupation, or class. This can be measured in a lot of different ways. In American studies, it's often measured by insurance coverage status, seeing if a patient has private insurance, public insurance, or is self-pay, as well as there are area-based scores looking at this as well. In the US, there's the ADI, or Area of Deprivation Index, which is probably the most common socioeconomic status score. It's based on zip code, and these zip codes are ranked as a percentile of deprivation relative to the national average. If you look at income, educational level, home value, and quality of life scores. There is a pediatric version of the ADI called the Child Opportunity Index, also an American score based on zip code, with 29 indicators over 3 key domains, looking at educational opportunities, health and environmental opportunities, as well as socioeconomic opportunities. In Canada, we have our own separate measures of social deprivation. We have the Canadian Index of Multiple Deprivation, or the CIMD. So this is area-based using postal codes and split into quintiles based off of 4 dimensions: residential instability, situational vulnerability, economic dependency, and ethnocultural composition. In Quebec, the Institut National de Santé Publique de Québec has their own index, the MSDI, or Material and Social Deprivation Index. The MSDI includes these specific 6 factors. So people without a high school diploma, looking at the employment rate, average income in a postal code, proportion of people living alone, single parent families, and amount of people who are divorced or widowed or separated. And all of these are standardized according to the age and sex structure of the Canadian population. You'll note that there is no race factor in this calculation as opposed to the previous Canadian one I discussed. And there are some external studies that are showing that it may underestimate inequalities. That being said, I think it's important to take a second to take a look to see how they sort of group these patients after indexing their various qualities. So you'll see here, this is how they would create a combined deprivation index. So they have a social deprivation index on this side of the axis and a material deprivation axis on this side. And then from there, you get an overall ranking from materially and socially privileged to lacking one or the other, or materially and socially deprived. Finally, I'd like to talk about adverse childhood experiences, which are also a social determinant of health. These are defined as potentially traumatic events occurring in childhood, like violence, abuse, exposure to family with substance use, or mental health issues. There is plenty of literature, especially in the pediatric, but also in the adult literature, showing how adverse childhood events are associated with many chronic health conditions later on in life, as seen here on the right-hand side, as well as with increased at-risk health behaviors, as well as further socioeconomic challenges in adulthood. 61% of adults in the US have at least one ACE, or adverse childhood event, with 16% having 4 or more. And that threshold really puts you at having a high risk of having further sequelae. And people at higher risk of having more than 4 or more ACEs include females and visible racial or ethnic minorities. And this introduces the concept of intersectionalism, which I will bring up again at the end of this talk, but whereby people with multiple negative social determinants of health, so visible minorities, gender minorities, females, often get other social determinants of health, so an increased amount of adverse childhood experiences. And those multiple negative social determinants of health have compounding negative consequences. So now I'd like to discuss what literature is out there specific in urology, looking at different disease states. I want to start first with pediatric urology, and we'll start by looking at testicular pathologies. So for cryptorchidism, you'll recall that both CUA and AUA guidelines recommend orchidopexy between 6 to 18 months of age. And there are a few studies looking at timeliness of orchidopexy. For example, a 2022 study looking at American NISQIP data demonstrated that Hispanic children, Black children, and American Indian or Alaska Native children had less timely orchidopexies. That means not fitting within that window of 6 and 18 months than non-Hispanic white children. A 2012 study looked at a national pediatric hospital network in the US and showed that 61% of children with private insurance had timely orchidopexies within that 6 to 18 month range, as opposed to 54% without private insurance. And just recently, last year, there was an American study looking at aggregate data from over 49 hospitals that basically combined the two, and it showed disparity between races, insurance status, and timeliness of orchidopexy. So this is just a table from the 2022 study out of the US looking at race. And again, you see, odds ratios for Black patients, Hispanic patients, and other patients, and American Indian or Alaska Native. You see the odds ratio here is 0.3, confidence interval 0.1 to 0.8. For Black patients, it's 0.6, with white patients being your reference of 1. So certainly lower for the odds of timely repair. And then this paper is the one from 2024. Looking again, we see even after multivariate analysis, less timely for Hispanic patients and those with public insurance status. Public insurance status, again, less likely to have timely orchidopexy, underwent orchidopexy an average of 2.94 months later. What was interesting about the 2024 paper is they had the opportunity to look at patients from a pre-COVID cohort, a during COVID cohort, and a post-COVID cohort. And what they saw is COVID did exacerbate some known health disparities. So if you take a look here, and this is for patients with public insurance. So the Black is pre-COVID, during COVID, post-COVID. And there was a significantly lower proportion of patients with public insurance in the post-COVID world that underwent timely orchidopexy, so 49% versus 42%. When we talk about testicular torsion, which we know is a pediatric surgical emergency, there is conflicting evidence regarding any healthcare inequities in this context. So I was able to find 2 single institution retrospective studies, one in 2022 that showed increased orchiectomy rates for those of other ethnicities, so non-Hispanic, non-African American, non-white, and a 2024 retrospective study which showed no difference in torsion salvage rates when looking at race or child opportunity index, which, if you'll recall, is that area-based index looking at socioeconomic status. Let's move on and discuss circumcisions. So neonatal ambulatory circumcisions are an elective procedure, but the access to this basic elective procedure is not necessarily equitable. And this actually is a very fertile ground of study, especially in the US, because circumcision is culturally widespread and Medicaid coverage of the procedure varies state by state. I think it provides an interesting opportunity to look at racial and income inequalities, and especially to look at how they're choosing to design these studies. So some studies have looked at formal operative circumcisions, so when a patient is taken to get a circumcision under general anesthetic in the OR, as a proxy for those unable to achieve easy access to ambulatory neonatal circumcisions, because those need to be done early on in life. However, ambulatory neonatal circumcisions are lower risk and have less complications than taking a patient to go under GA. And there are higher rates of ambulatory circumcisions in states where this procedure is covered by Medicaid, and there are more formal operative circumcisions in states where Medicaid does not cover ambulatory circumcisions. So there was a study that basically looked at states where neonatal ambulatory circumcisions were previously covered by Medicaid, and then that coverage was discontinued. And they showed that this discontinuation disproportionately impacted the number of Black infants receiving the procedure. So when Medicaid coverage was available, Black infants had a higher odds ratio than white infants of receiving an ambulatory neonatal circumcision of 1.44. However, once that coverage dropped off, Black infants suddenly switched, and they had a lower odds ratio than white infants, down to 0.4. Certainly, of course, there could be other confounding factors, like perhaps a change in cultural preferences, but it would be unusual for a change of cultural preferences to occur so quickly within the course of a couple of years. There have been other studies showing that boys are more likely to have a formal circumcision in the OR if they have public insurance instead of private insurance, and that the largest proportion of boys who have formal OR circumcisions are in the lowest quartile of income. So those who are economically deprived, oftentimes perhaps don't have access or the ability to pay for ambulatory circumcisions, and then proceed with formal circumcision later on in the operating room. And again, I'll remind you that a formal circumcision is associated with more complications, risk of general anesthetic, and things like that. So let's move on to pediatric surgical complications, our last sort of pediatric section. So in terms of pediatric surgical complications, there was a study of US NSQIP data showing that Black children had higher odds of 30-day overall complications and higher odds of hospital-acquired infection, so odds ratios of 1.34, 1.54, even after adjusting for other procedure confounders. Interestingly, there's a similar study being done right now here in Vancouver with the group at BC Children's looking at all pediatric surgeries, and they're looking at socioeconomic status using that area-based rate from Canada I told you about before, the Canadian Index of Multiple Deprivation and Surgical Complications, and they found no significant difference between SES deprivation levels and surgical complications. And I think this highlights, and I'll bring this up later in my talk, the importance of having local data and local research in the area, because just because something is true in one cultural context doesn't make it true broadly everywhere. I'd like to transition now into adult urology, and we'll start first by talking about trauma. So one of the most common types of trauma we see as urologists is renal trauma. And this begs the question, is renal trauma affected by inequities? And one American study of all ages renal trauma showed that being Black was associated with higher mortality. I included one of their figures here on the right-hand side. You'll see white, their log odds was 0, so that's their standard. And then here is what they have as their risk for Black people with mortality for renal trauma. Interestingly, a multi-center study showed that race as well as insurance status was not associated with mortality in pediatric renal trauma. Plenty of reasons why this could be. It could possibly be that mortality from pediatric renal trauma is already so low at baseline that any possible risk factors do not affect it. Let's move on to lower urinary tract symptoms, something that I think many urologists see on a daily practice in their clinic. So I want to take a moment to discuss this sort of groundbreaking study that occurred in 2007, published in the EAU from the Boston Area Community Health Survey. And basically, it laid the groundwork for correlating historical abuse with current lower urinary tract symptoms. It was a large epidemiologic study of all genders, and it inquired about a previous history of physical, sexual, and emotional abuse as a child or adolescent. They looked at lower urinary tract symptoms in the form of frequency, urgency, and nocturia, and demonstrated an increase in all domains with a history of previous abuse. And a strong argument is really made in the paper about the causality and not just correlation between previous abuse and increased LUTs. And they use many sort of statistical tests to sort of try to reinforce their argument of causality. So here are just a couple of the figures. Sorry, I realize the writing's a bit small depending on how large your screen is, but I'll walk through them with you. So you see here on this axis, we're looking at the different forms of abuse, either in childhood or adolescence. And then what we have here is the 3 lower urinary tract symptoms measured: frequency, urgency, and nocturia. The black line here is sort of your odds ratio, so 1 being no effect. And all of these small letters up here, they broke up their cohorts into separate subcategories, O being overall, M being men, F being women, B being Black, African American, H being Hispanic, and W being white. And what you'll see is overall, really across all types of abuse and across all lower urinary tract symptoms, that the odds ratio is positive, right? So you really see associations with all lower urinary tract symptoms. Furthermore, here's another figure from the paper, and they basically take a look and see these are, again, different types of abuse, and this is the lower urinary tract symptoms. But here what we see is the increasing prevalence of lower urinary tract symptoms with increasing frequency of historical abuse. So you'll see here that the increasing prevalence really goes up. There's an upward trend for all of these graphs, basically. So this is sort of part of what they were using to demonstrate that this history of abuse is not just correlated, but indeed may even have a causality relationship with lower urinary tract symptoms. So building off of this, there was a recent study just in 2023, an American study looking specifically at women aged 32 to 47 and looking at adverse childhood events and voiding function. So they looked at exposure to adverse childhood events and measured their lower urinary tract symptoms with the Incontinence Impact Questionnaire and the AUA Symptom Index. Very interestingly, though, they had a hypothesis that adverse childhood events would be related to lower urinary tract symptoms, but that they would try to measure resilience and see if this mitigated the effect. And they decided to measure resilience by looking at the extensiveness of social networks, with the idea that if someone has more social connections, that perhaps this helps build resilience and can mitigate those previous childhood events. So this is their questionnaire for adverse childhood events. So these are the ones they chose to look at. So how often did a parent make you feel like you were loved, supported, or cared for? How often did an adult in the household swear at you, insult you, put you down, or act in a way that made you feel threatened? How often did a parent express physical affection for you? So hugging, other physical gestures of warmth and affection. How often did an adult in the household push, grab, shove, or hit you so hard you had marks or were injured? And did you live with anyone who was a problem drinker, alcoholic, or who used street drugs? And this is their social networks questionnaire. So again, using how many social connections someone had as a way to indicate possible resilience and basically the opposite of social deprivation. So how many close friends do you have? How many relatives do you have that you feel close to? And do you belong to any of these kinds of groups? And they had social and recreational groups, labor unions, commercial groups, professional organizations, church groups, PTA, Boy Scouts, charity groups, or any other groups. They really tried to cast the net wide here. And what they saw is that more frequent adverse childhood events were associated with more female lower urinary tract symptoms. And you can see that here in both these figures, you can see if your ACE was 1 standard deviation over the mean, you had a higher likelihood. This is for moderate and severe LUTs, and this is for mild, moderate, and severe LUTs. But interestingly, if you look at the dotted line are those whose social network was 1 standard deviation over the mean, whereas the solid line is if they had a social network that was 1 standard deviation under the mean. So basically what they said is having a more extensive social network seems to attenuate this effect. Indeed, it even flattened it when we came to moderate or severe LUTs. And for all LUTs, it did seem to lower it a bit. Basically showing that although I think it's important to recognize that these adverse childhood events can affect current lower urinary tract symptoms, it is not a one and done, can never be changed thing, and that there are potential steps that adults can take or social factors that can influence how much this would affect their lower urinary tract symptoms as adults. And finally, for my last point of the sort of a disease review, we come to oncology. So upper tract urothelial cancer, there was a single center retrospective study looking at patients undergoing NEFR-U or ureterectomy and classified by ADI. Again, that's that American Area Deprivation Index looking at socioeconomic status. The tumor characteristics were similar between groups, and the median DFS and OS were the same for both groups. Interestingly, analysis with logistic regression showed that those with worse ADI, so those who were socioeconomically deprived, were associated with a lower rate of neoadjuvant chemo, although quartile analysis did not show significance. And I think this does raise the question, are we giving everyone equal access to all treatments? Patients who may have a more difficult socioeconomic status, is it harder for them to access frequent medical appointments, things like that, to get neoadjuvant chemo? I next want to talk about prostate cancer as our final topic. So there was a robust 27-year retrospective cohort study published recently from the Detroit area, 134,000 patients. And they were looking at lethality in prostate cancer and how this related to race and socioeconomic status. So lower socioeconomic status, high ADI, was associated with decreased prostate cancer incidence, but the worst ADI had the highest lethality. So this could certainly be to poor screening, could also be due to other comorbidities leading to lethality. When looking at just non-Hispanic Black people, the increased ADI, so lower socioeconomic status, was associated with increased prostate cancer incidence. So the exact opposite of what it was for all comers. And interestingly, Black people had increased lethality for every single ADI quartile. So looking at their socioeconomic peers, Black people had increased lethality. However, there have been multiple studies in the Canadian system that have not seen a similar increased lethality for Black Canadians with prostate cancer. And this, I think, is really interesting because it really does pose the question, does race have the same effect in different cultural contexts? And the answer, based on these Canadian studies, seems to be no. In different countries, we see that Black Canadians don't necessarily have the same risk factors as their Black American compatriots. So these are just some figures from that large Chicago study. You'll see here in the purple, this is the purple line. So those who were the most socioeconomically deprived, and you see here that their incidence was lower, but their lethality is much higher here. And then I think it's interesting to also discuss that there are racial disparities also in pharmacologic trials. So this paper really aggregated a bunch of the trials for some of the big prostate cancer treatments, so apalutamide, darolutamide, fluciclovin, so PSMA PET, and showed that the percentage of Black participants in this trial, under 10% easily for each. And Black people make up 14.4% of the US population. So if we assume that a large proportion, or at least some of these trials, were done in the US, this isn't a representative proportion of the US population. And, racial disparities do exist in the Canadian system too. There was a prospective cohort study from Alberta looking at prostate cancer outcomes in Indigenous versus non-Indigenous men. And Indigenous men were less likely to have PSA testing, more likely to be diagnosed with higher grade and higher stage tumors, and had increased odds of metastasis. There was no difference in disease-free survival or in overall survival over 40 months. And the authors point out it's unclear if the results can only be attributed exclusively to decreased screening or if there's also an element of more aggressive tumor biology in this population. And this is just a survival curve of metastatic-free survival from that study. And so those are Indigenous people in the blue, non-Indigenous in the red, and you can really see that there is a significant difference in metastasis-free survival. So now that we've established that this is an issue in, many different fields in urology, the question begs itself, well, what can we do about it? What are possible solutions? And there are solutions from both a research standpoint and from a clinical standpoint. I think from a research standpoint, a really promising area of research is community-based participatory research. And I want to draw attention to a letter from the editor published in August 2022 by the Journal of Urology about patient engagement in urologic research. So what is community-based participatory research? It's basically, they define it as a way to engage community members, not as subjects, but rather as partners, involving the community in every stage of research, ideally from identifying the study question at hand to developing an intervention, recruiting participants, collecting data, interpreting research findings, delivering interventions, and disseminating results. So basically having patient advocates with you at every step of the research process and really making them part of the research team. Now, community-based participatory research has been successful in increasing participation of racial and ethnic minorities. There have been some studies on that, as well as increasing the readability and accessibility of research materials, so that patients can really benefit from the research being done about diseases that affect them. Another strategy, but both from a research and a clinical standpoint, that I think will be helpful in combating social determinants of health is personalized medicine. So the use of protein or RNA biomarkers for disease prevention, early diagnosis, improved prognosis, and treatment. So for example, in prostate cancer, genomic studies have shown different androgen receptor polymorphisms like high-frequency repeats and DNA methylation in certain African populations or ethnicities, which are indicators of higher risk disease. And there are also differences in immune-oncogenic pathway genes implying more immune-related pathway alteration in African men. So really, what the goal is to recognize that not everyone has the same risk factors and to use individualized biomarkers instead of relying on external categorization, right? In a perfect world, we don't look at someone and say, oh, well, you're Black, so you'll probably have an increased risk. We can test for all of these different androgen receptor polymorphisms and these pathway genes and say, well, specifically because you have these mutations, this is the medication that you should be taking, and you are at high risk because of this. That being said, I think it's important to also just mention the ongoing inequity in genome-based studies. So this infographic comes from a paper looking at basically an aggregate of a lot of genome-based studies showing that African people make up 2.4% of the genome, others make up 19.6%, with European making the vast majority at 78%. And if we don't collect a diverse genome, we're not going to be able to study gene lines efficiently and study proteins that can affect people of all ethnicities instead of just a specific group that's collected in our genome. And then in terms of research, we should also talk about creating better measures of health inequity. We've gone over a few today, and we've discussed how area-based measures of inequity are preferred to single factors because they're more holistic and they take multiple things into account. I've mentioned multiple times the ADI, the Area Deprivation Index, which is a US measure, but it's not perfect. It's been critiqued for placing too much weight on housing prices. It underassesses areas with low housing costs and overassesses areas with high housing costs and disadvantages rural and impoverished areas. A recent paper published in 2023 gave 5 recommendations for robust and unbiased social deprivation measures. So as we create new social deprivation measures, it's important to clearly describe methods of creation, including the reasoning behind variables and coefficients. So saying, well, why you picked certain variables, make the measure code publicly available, and that's to ensure reproducibility. These measures should be made with a multidisciplinary team of social scientists, subject matter experts, and statisticians. And these should not be static. There should be a routine updating and reevaluation of the indices as neighborhoods change and as risk factors change. And finally, in terms of validity, there should be an opportunity to use public feedback to verify the ground truth of the results of your measure. So now that we've looked at how we can improve things from a research context, what about from a clinical context? So a pilot project in North Carolina implemented screening for social determinants of health at a urology clinic. And they were the only urology clinic in their county targeted specifically to serve uninsured and underinsured patients. So this is a special population, but they looked at domains of food insecurity, housing instability, lack of transportation, and interpersonal violence. So the way this worked is patients were given the paper screener in the waiting room, and those with low literacy went through it with a nurse in the clinic room before the doctor came in. The results were stored in the EMR, and if the patient screened positive for a need for a social determinant of health, nurses provided pre-printed community resource guides. Of course, this kind of system has resource limitations. You really need dedicated support staff to be able to do something like this. This is a picture of their screener. So again, they look at food insecurity, housing and utilities, transportation, like a lack of transportation keeping you from medical appointments, and interpersonal safety. Interestingly, this question here is an immediate need question. So are any of your needs urgent? For example, you don't have food for tonight, you don't have a place to sleep tonight, you are afraid you will get hurt if you go home today. So that was able to flag it to people taking the screener that, if you needed immediate aid, they'd be able to help. From this study, 30% of patients screened positive for at least one need. And of course, recall that this population is, this clinic specifically targets underserved, underinsured people. But interestingly, 100% of surveyed clinicians and office staff agreed or strongly agreed that screening was valuable. And respondents indicated that screening patients once a year would be moderately to highly feasible. And this is in a urology context, not in a primary care context. And I want to bring up this idea of screening to again reinforce this concept of intersectionalism. So the concept that if you have multiple needs in social determinants of health, like race, gender, sexual orientation, socioeconomic status, this can compound and exacerbate social disadvantages. So it's important to be aware of all factors and not just one. What about here in BC? Currently, many health authorities allow for patients to voluntarily self-identify as Indigenous, and Indigenous patients have access to patient liaisons. These are all the health authorities, and they all have a version of a patient liaison, or patient navigator, a liaison nurse. These are mixed inpatient and outpatient services to help Indigenous patients navigate the healthcare system and connect patients to banned resources, spiritual practices, and culturally relevant care. And this is in addition to social work. So this is an extra resource specifically for these people who we know have what we call a negative social determinant of health. Of course, there's always more we could do as the province transitions into electronic medical records. I think certainly we could consider adding a section for anticipated social challenges, things like poor access to transportation, difficulty accessing childcare, stating that someone prefers virtual visits or has a history of previously disclosed healthcare trauma that may make them a bit more skittish or jittery of the healthcare system. This could be flagged at every visit automatically, perhaps include an automatic referral to social work, and even could include an automatic referral to loop primary care provider into these issues. So I think a little bit of this exists in some EMRs, but this is just a suggestion for things we could look to in the future for how we could continue being aware of social determinants of health as we progress, throughout our course treating patients in hospital and in clinic. So overall, today we've talked about how social determinants affect every aspect of urology and how tools to account for social determinants of health can be implemented in both a clinical and a research setting. Importantly, I think you'll note that a lot of the studies I quoted were American, and that's because there isn't really a lot of research in a Canadian context. And I've presented Canadian studies where I've been able to find them. I think ultimately more research needs to be conducted to evaluate this in a Canadian context, because I think as we've seen from the Canadian studies, our findings here in Canada may be different than the findings in America because we have a different cultural context. And with that, I'd like to open the floor for questions. Thank you for your attention today.